If you have Sjogren's syndrome or fibromyalgia, I need you to take off your shoes right now because there are 7 specific changes happening in your feet that most doctors miss, and every single one of them could be signaling serious nerve damage that's already progressing. Stay with me, because by the end of this video, you'll know exactly what to look for, what it means, and what you need to do before it gets worse. We're going to go through a complete clinical self-assessment, the kind of checklist that most patients never receive, and I promise you, by the time we're done, you will never look at your feet the same way again. Before we go any further, please note that this video is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always consult your physician or a qualified healthcare provider with any questions you have regarding a medical condition. Never disregard professional medical advice or delay seeking it because of something you've heard in this video. I'm a clinical nutritionist, and over the past 15 years, I've worked extensively with patients managing autoimmune conditions like Sjogren's syndrome and complex chronic pain disorders like fibromyalgia. And here's the thing, these 2 conditions share something that neither patients nor many general practitioners fully appreciate. Both carry a significantly elevated risk of peripheral neuropathy. That is nerve damage that attacks the longest nerves in the body first, which is exactly why the feet are always ground zero. The clinical reality is sobering. Studies suggest that up to 55% of Sjogren's patients develop some form of peripheral neuropathy over the course of their disease. In fibromyalgia, small fiber neuropathy is now confirmed in peer-reviewed research as a coexisting condition in a substantial proportion of patients. These are not rare edge cases. These are your fellow patients, and quite possibly you. But that's not even the most shocking part. The real danger isn't the nerve damage itself, it's the fact that patients and even many general practitioners dismiss foot symptoms as just part of the flare. Just fibromyalgia doing its thing. Just Sjogren's being difficult. This delay in recognition and investigation costs patients dearly because nerve fibers, once lost, do not reliably regenerate. Every month that passes without the right diagnosis is a month of irreversible progression. So, what exactly are these 7 changes? Let's go through each one carefully because you need to recognize these on your own body. Now here's where it gets interesting and urgent. I want you to understand what's actually at stake when peripheral neuropathy is missed or ignored in someone with Sjogren's or fibromyalgia. There are 3 escalating consequences that I've watched unfold in my practice, and they paint a picture you need to sit with. The first is progressive loss of protective sensation. Your feet stop feeling the pain signals that warn you of injury. A shoe rubs, a cut happens, a pressure point develops, and you feel nothing. The wound deepens silently while you go about your day. This is not a theoretical risk. This is the clinical trajectory of untreated neuropathy. The second consequence is autonomic neuropathy involvement. The autonomic nerve fibers that regulate blood flow to your feet become damaged. Circulation becomes erratic and compromised. Skin changes that start as subtle observations become permanent structural damage. Temperature regulation in the feet fails entirely. The third and most advanced consequence is motor nerve involvement, muscle weakness in the foot, instability, and a dramatically increased fall risk. Falls in patients with chronic illness are not minor events. They are catalysts for cascading health decline. I had a patient, a 47-year-old woman with Sjogren's, who had been telling her rheumatologist that her feet felt like they were wrapped in wet cotton for 2 years. For 2 years. By the time she came to me, she had lost significant sensation in both feet and had developed a wound on her left heel she hadn't even felt happen. 2 years of a clear warning sign, completely normalized and dismissed. You deserve to know these signs. Your doctor may not have flagged them, but I'm going to. I'll reveal the exact protocol in a moment, but first let me explain how to use this list properly. Grab a notebook, get a good light source, natural light if possible, and sit somewhere you can examine both feet simultaneously. What I'm going to describe falls into 2 categories. Neuropathic symptoms are what you feel. Neuropathic signs are what you can observe. I'm going to cover both, because nerve damage shows up in how your feet feel and how they look, and you need to track both categories. One of the most consistent patterns I see in my practice is that chronic illness patients normalize their symptoms. They've been in pain and discomfort for so long that new or changing sensations get absorbed into the background noise of their condition. That normalization is exactly the problem. The 7 signs I'm about to describe may sound familiar to you, and that familiarity is precisely why I need you to hear them clearly and take them seriously. Let's start with sign number 1, and this one surprises almost everyone. Sign number 1 is burning or electric pain that's worse at night. The clinical term for this is small fiber neuropathy-mediated burning dysesthesia, but what patients describe is more visceral than that. It's a deep, relentless burning like sunburn on the inside of the foot, electric shocks that shoot through the toes or along the arch, pins and needles that intensify the moment you lie down to sleep, just when you're desperate for relief. Why is it worse at night? 3 converging reasons. First, distraction is removed during the day. Activity and mental engagement dampen pain perception through descending inhibitory pathways. At night, that dampening disappears. Second, circulation changes when you lie down, shift blood flow patterns in the lower extremities. Third, cortisol drops in the evening, and cortisol has natural anti-inflammatory and pain-modulating effects. When it falls, neuropathic pain signals amplify. Here's the clinical red flag that distinguishes neuropathic burning from general fibromyalgia pain. If this burning is specifically localized to the feet and lower legs, if it has a burning or electrical quality that feels distinct from your usual widespread fibromyalgia discomfort, and if it consistently peaks at night, this warrants a neurological evaluation. Specifically, a skin punch biopsy to assess small fiber nerve density. I'll come back to that test in detail shortly. Your action point for sign 1, rate this pain on a scale of 1 to 10 and note the specific time of day it peaks. If it consistently peaks at night, is burning or electrical in quality, and is localized to the feet and lower legs, document this precisely for your next medical appointment. Sign number 2 is skin color changes, specifically mottling, pallor, or unexplained redness. Think about it. When did you last actually look at the tops of your feet and your toes with this question in mind? The clinical explanation involves your autonomic nerve fibers, which control the tone of blood vessels in the feet. When these fibers are damaged, vasomotion, the rhythmic constriction and dilation of blood vessels, becomes erratic and unreliable. What you see as a result is patchy red and white mottling, sometimes in a net-like pattern called levato reticularis, or persistent pallor in the feet, even when the rest of your body is warm, or unexplained flushing and redness of the toes and forefoot. For Sjogren's patients specifically, I need to flag something important. Sjogren's can independently cause vasculitis, inflammation of blood vessel walls, which also produces skin color changes. So in this population, color changes need careful differential diagnosis. The neuropathic component specifically involves asymmetric color distribution and measurable temperature differences between affected and unaffected zones of the same foot, or between the 2 feet. Here's a practical clinical tool I teach my patients: the back of hand temperature test. Hold the back of your hand against the top of each foot in turn. A noticeable temperature asymmetry between the 2 feet, where one is significantly cooler or warmer than the other, is a clinical flag that warrants documentation and discussion. In fibromyalgia, autonomic dysfunction is well documented, including Raynaud's-like symptoms and broader dysautonomia. Color changes in fibromyalgia patients may represent neuropathic autonomic involvement rather than pure vascular disease, which means the treatment approach differs significantly. Your action point for sign 2: photograph your feet in natural light at the same time each day for 1 week. You're looking for patterns of color asymmetry, not just day-to-day variation, but consistent differences between the 2 feet or between different regions of the same foot. Sign number 3 is skin texture changes, specifically thinning, shiny, or severely dry cracking skin. Stay with me, because this one is genuinely underappreciated. Your autonomic nerve fibers also control the sweat glands in your skin through a process called pseudomotor function. When nerve damage disrupts this signaling, the skin of the feet loses its normal moisture regulation from the inside out. The result is skin that looks and feels distinctly abnormal. Abnormally shiny, thin, almost translucent skin on the top of the foot and the toes. Severe dryness with deep cracking, particularly at the heels, that simply does not respond to moisturizers no matter how diligently you apply them. And loss of the fine hair on the toes and lower legs, which is another autonomic sign that patients and clinicians alike rarely connect to nerve damage. Here's the key distinction from ordinary dry skin. Normal dry skin responds to consistent moisturization. Neuropathic skin texture change is structural and progressive. The skin has lost its ability to self-regulate moisture because the neural signals that drive sweat gland activity are damaged. You can apply the best moisturizer on the market every single night, and the underlying cause is not being addressed. For Sjogren's patients, I want to be specific. Sjogren's causes systemic dryness, eyes, mouth, skin throughout the body. But foot skin that is specifically shiny, noticeably thinned, hairless, and distributed in what we call a stocking pattern from the toes upward is neurologically significant beyond the generalized dryness of the condition. It is telling you something different. A practical test I use in practice, the pinch test. Gently pinch the skin on the top of your foot between your thumb and forefinger. Now do the same on the back of your hand. Neuropathically affected foot skin often feels distinctly thinner, less elastic, and almost papery compared to the skin on your hand. Your action point for sign 3. Compare skin texture on the top of both feet and note any asymmetry between the two sides, and compare to non-affected body areas. Sign number 4 is numbness or reduced sensation in a stocking pattern, and this is the hallmark sign that most clinicians recognize, but that patients remarkably often fail to identify in themselves.